let's talk about anxiety and obsessive compulsive disorders. So we are going to talk about a couple of different disorders. Um, Separation anxiety, talking about some phobias, social anxiety, panic, agoraphobia, and then some other disorders related to obsessive compulsive and body-related issues. So first we're going to talk about separation anxiety, which is often a response to trauma. So with it, separation anxiety, the key here is really noticing if something is developmentally inappropriate based on their age. And we have criteria here based on kids and adults. So we're looking at excessive anxiety concerning separation from either home or person, going on for at least 4 weeks for kids and at least 6 months for adults. So you see there's a very big timing difference. And again, based on our diagnostics from previous sections, we know that timing of symptoms is really important. So we need to be sure as you're going through intake interviews to pay close attention to how long things have been going on, because the timing is really critical when it comes to diagnosing certain things for adults and kids. So separation anxiety requires someone to meet criteria of at least 3 of these symptoms. Recurrent or excessive distress when being separated from home or a major attachment figure. So thinking about attachments related to parents or a spouse perhaps, and this is either actual separation from these individuals or anticipated separation. So they become very nervous when they know perhaps someone is going to travel or going to be away from them or going to school, so you won't be able to see them for a while. Beyond that, persistent and excessive worry about losing or possible harm. So we think something's going to happen to these individuals. I'm worried my spouse is going to die in a car crash or a plane crash if they go on this trip. I'm worried that while I am at school, something bad might happen to my parent because I'm not there. Beyond that, there's also worry that some sort of sudden event will lead to separation of that major attachment figure. So for example, particularly for kids, that will be, I'm going to get lost, I'm going to get kidnapped. Also potentially worrying about this as an adult. So I'm worried that my spouse is going to get kidnapped or something when they travel. Persistent reluctance and refusal to go to school or elsewhere because of a fear of separation. So this might be for kids, obviously they can't go to school or daycare, go stay with other trusted adults. For adults, this might be reluctance to go to work or to have extended periods of absence from a loved one, like a spouse or a kid or something like that. Next criteria is you're going to notice the persistent and excessive is present in a lot of these criteria. So persistent meaning that it's happening pretty frequently, if not constantly, and excessive, again, being beyond what's developmentally appropriate and beyond just general anxiety, but very targeted towards what's going on. So reluctance to be alone or without that attachment figure, either with at home or in other settings. Refusal to go to sleep without being with them or to sleep away from home. Again, this is just as true for kids as adults. Nightmares involving themes of separation or loss, and repeated complaints of physical symptoms like headaches, stomach aches, nausea, especially for kids because they don't always have the language to describe anxiety when separated from that major attachment figure, or again, that anticipation piece. So this is not the same thing as trying to control someone else by attaching to them really strongly. This is not the same as social anxiety, so we're not just afraid of being around other people, and it's not a phobia related to an environment. So we have to make sure that there's no other explanation for what's going on, and it really is about separation from that attachment figure or from a safe environment like home. So then looking at similar criteria, but specific to social settings, we would be looking at social anxiety disorder. And for kids especially, this must be with both peers and adults, not just one or the other. So here we have fear or anxiety of social situations, when you might be potentially under the scrutiny of others. So thinking about having unplanned conversations, meeting new people, going to new environments, perhaps giving a speech. So this can be specific to like performance-related issues. But this is a person who rehearses things over and over in their head before they go have a conversation because they're worried something bad is going to happen in this social interaction. There's a fear of or anxiety symptoms, and fear that these anxiety symptoms will be noticed by others. So they'll feel embarrassed or rejected because of that anxiety. Social situations will almost always provoke fear or anxiety, so this is not specific to any one particular situation. It's pretty consistent across social situations. So again, almost always in almost all situations, to the point where these situations are avoided or they're really exhausting, honestly, because of intense fear or anxiety. And knowing this, it's really important to consider that coming into a therapy space and a therapy office is probably really intense and really draining for clients who have social anxiety disorder because of that fear or anxiety of the unknown. That fear or anxiety has to be out of proportion to the actual danger that's posed, so there's no reason for this person to be so nervous about the social context that they're going to interact with. This has to be going on for at least 6 months or more, again, persistently and consistently, and causing distress or impairment across dimensions. So it's not just, I'm afraid of going to work because my boss is hypercritical of me. It's consistent across all. And there is a specifier for performance-related anxiety, so this is specific to public speaking or some sort of performance situation. So then we're going to get into talking about specific phobias. And we'll talk on the next slide about the specific areas in which a person can have a phobia, but we're going to talk about phobias in general first. So this is marked fear or anxiety about specific objects or situations. So they are pretty specific as indicated by the title. And this is marked fear or anxiety about one specific thing as opposed to things like social anxiety where it's across the board in most situations. So that object or event almost always provokes fear. So again, those terms of persistently and consistently are still important. And it's to the point where you're actively avoiding that object or that situation because of that fear and anxiety. And so for children, this might look a lot like crying or tantrums or freezing or clinging to an adult. For adults, these might look like actively avoiding things, going out of your way to avoid things, or missing out on aspects of life because of this specific phobia. It has to be out of proportion to the actual danger posed in consideration of the social context. So this is not something that's actually a threat to that person. It's just based on perception. Again, has to have been happening for 6 months or more with distress and impairment across dimensions. And we have to rule out things like overall anxiety, social anxiety, panic disorders, and things like obsessive compulsive disorders because what looks like a phobia may actually be part of the ritualistic aspects of obsessive compulsive disorder. So some examples of specific phobias might include things like animals, so fear of spiders or snakes or dogs, bugs, birds, things like that. Again, to the point where you're actively avoiding these things. There can be fear of the natural environment, so maybe heights, tornadoes, hurricanes, floods, natural disasters, and again, out of proportion to the fear. So there may not be a huge risk all the time, but someone feels the need to perhaps be hypervigilant to prepare for these events just in case. There's blood injection and injury related phobias. So this is your fear of needles, your fear of blood, your fear of invasive medical procedures, fear of anesthesia, for example. Then there's situational things like airplanes, fear of elevators, fear of being underwater. We call this claustrophobia, small spaces. And then there are generally other types of phobias that exist. So phobias of choking or vomiting or doing these things alone because you're afraid that you'll asphyxiate and die. Phobias of loud sounds, which again might be a trauma response, and things like clowns that are scary. And we always want to rule out a symptom of PTSD and make sure it's really specific to that phobia. So another example of a phobia is agoraphobia. This is marked fear or anxiety about potentially a couple of different things. So it could be a fear of public transportation, so fear of subways or buses or planes. And this is more about being in that setting than it is about something awful happening, like a plane crash. Being in open spaces, so being nervous, potentially about being in empty parking lots, being in big stores. This is about not feeling like you have a sense of escape. Being in enclosed spaces like a movie theater, being in crowds of people, or just generally being outside of the home. And I know when we think about agoraphobia, probably what comes to mind is that individual who's homebound and is afraid to leave the home. I have worked with some clients who struggle with agoraphobia. We started out with the telehealth setup in order for them to be able to start working from the home and then actually work towards them coming to the office as that being a means of trying out leaving the home in a sort of safe and controlled space. So, doing things like sending them pictures of the office, talking through and rehearsing in their mind, going into the office, knowing how many doors they'll have to go through, how many people they'll have to interact with, and that being sort of a safe way to bridge that gap. So this is fear avoidance due to thoughts that they won't be able to escape, something bad might happen, or that they'll experience a panic attack, which will be really embarrassing for them. And consistently and persistently, the situation provokes fear and anxiety for the individual out of proportion to the actual danger posed, going on for at least 6 months or more. Next, we have panic disorder. And so there's panic disorder, but then there's also panic attacks as a specifier that can be used with other anxiety or phobia related diagnoses. And so you'll want to make sure that the primary thing is the panic part, not anxiety with some sort of occurrence of panic attacks, which is really secondary to the anxiety related symptoms. So ruling out if this is the most appropriate diagnosis or if there's another more appropriate diagnosis with a specifier for panic attacks. So with panic disorder, we're looking at recurrent and unexpected panic attacks, which is really this intense fear and discomfort. And this has to go on within a short amount of time and experiencing some of these symptoms. And when we think about panic attacks, we might think about that sort of traditional or classic like loss of breath, feeling like you're having a heart attack. But not all panic attacks are like that. Some of them can be very quiet and look very different. So noticing that all of these symptoms are equally indicative of panic disorders, no one is more appropriate for diagnosis than others. They just have to have 4 or more of them. So we have things like palpitations and a pounding heart, which we kind of think about when we traditionally think of panic disorders, sweating, trembling, shortness of breath, feeling like you're choking, and chest pain. But also this can look like nausea or stomach issues. Again, this comes on quickly, so it's not something that's going on persistently and consistently this time. Panic disorders are not consistent and persistent. Panic disorders are sudden but recurrent, meaning they happen quickly, they subside quickly, and then they happen more than once. So one panic attack does not equal a panic disorder. So we might have things like dizziness, lightheadedness, nausea, chills, feeling really cold or feeling really hot, numbness or tingling in the body. There can be depersonalization or dissociation that happens, and then just a lot of fear. So when individuals talk about panic disorder, panic attacks, they might just talk about this fear of dying or feeling like they're about to die because everything just feels so overwhelming. So this panic attack needs to be followed by at least 1 month of either persistent worry about having another panic attack or changing behavior to avoid things that would trigger a panic attack. So it's so severe and it's so recurrent that it's interfering with typical life. And again, we want to rule out the influence of any kind of physiological explanation or substance use. So next is generalized anxiety disorder, and this is more of a mild anxiety disorder. This individual experiences anxiety and worry on more days than not for at least 6 months about a variety of things. So it's not a specific phobia, it's not social anxiety, it's just general. And there's sort of a running joke that grad school and generalized anxiety disorder are synonyms because individuals in grad school probably feel a lot of excessive anxiety and worry more days than not for at least 6 months during their program. I know that was a running joke in my cohort in our graduate program that ours was a generalized anxiety disorder cohort. So this worry can be difficult to control and interferes with life and causes distress across dimensions. And anxiety is associated with either restlessness, feeling on edge, feeling easily worn out or tired, difficulty concentrating, irritability, muscle tensions, or difficulty sleeping. So with adults, we need 3 or more of these symptoms. With kids, we only need 1. And again, we always want to rule out physiological issues, side effects of medications, or substance use. The next we'll get into a few disorders related to obsessive compulsive disorder or compulsive disorders. Okay, so let's talk about OCD. So it's really important to delineate the difference between obsessions and compulsions because these are really 2 different things. So obsessions are recurrent and persistent thoughts or urges. These are like impulses. These are like the itch that you have to scratch. And it may be really easy to think, well, if you have an obsession, just don't do that thing. But it's the same as like having a really itchy spot and then not itching it. After a while, you just sort of have to. And if you don't, all you can pay attention to is how much it's itching. So at some time during this experience of this urge or impulse, there's it's an intrusive and unwanted, meaning that it's not something that makes sense. It's something that is beyond what would be considered reasonable, and it causes anxiety or distress for that individual. And so when that individual attempts to ignore, suppress those thoughts, there's some sort of like feeling of discomfort. So thinking about you have this feeling of overwhelming anxiety or stress, like something bad's going to happen, like you're going to die. And the only way to make that feeling better is to do whatever the obsession is. And so you have to neutralize them with some sort of action. And that's where the compulsions come in. So the compulsions are the way that an individual with OCD addresses the obsessions. So compulsions are the way to address the obsessive thoughts or the recurrent thoughts that are happening. So compulsions are repetitive behaviors, things like washing hands, things like checking to make sure that the oven's turned off or checking to make sure the door is locked, putting things in a certain order, or things that can be going on in your mind. So, praying or doing Hail Marys or counting things over and over again. In the course page, there's linked a couple of example videos of OCD that show some different types of symptoms demonstrating compulsions that can be helpful. But sometimes it's even things like saying a word over and over again. And so that individual feels like they have to do that to alleviate the obsession. And this is a pretty rigid thing. Like there is no waiting to do this later. There is no, oh, this is inconvenient, I'm not going to do it right now. The compulsion takes the front seat over anything and everything else. So you might be completely exhausted and ready to go to bed and wanting so badly to sleep, but you can't because you haven't finished your compulsion of brushing your teeth as many times as it feels like you need to for it to be right. And you don't always know when that's going to be. So these mental acts are aimed at preventing or reducing that anxiety or stress. They can be preventing something bad. So if I don't brush my teeth this many times, my teeth are going to fall out. And they're not realistic or in any way connected to a practical type of setting. So it's not like, oh, the dentist told me I need to floss twice. It's I have to because I feel like my teeth are going to fall out of my head if I don't. And it's clearly excessive. And so the obsessions and compulsions together have to be very time consuming. So this is taking more than an hour per day or cause clinically significant distress. So these things take up a lot of time and energy and attention. It's a pretty miserable experience to have OCD. And so when people make jokes about, oh, I like things to be very neat, I must have OCD, it's really minimizing the suffering of individuals who do have this diagnosis because it is very debilitating. And the process of treating OCD is very long term and requires a lot of intervention and work for the individual. The next is body dysmorphic disorder. And this is a piece of art that's meant to show what it's like to live with this type of disorder. So I encourage you to pause for a moment, pause the video, and take a look at this piece of art that depicts the feeling of having BDD. So body dysmorphic disorder, or BDD, is a preoccupation with one or more perceived defects or flaws in a physical appearance. And this is not something that others are able to see. So this might look like, oh my gosh, everything's wrong with my body. Or it might be specific to my nose is really big, or I feel like there's something wrong with me. These are individuals you might see um, seeking out things like plastic surgery to address these physical flaws that are apparent to this individual. And so at some point, this individual has performed repetitive behaviors, things like checking in the mirror to make sure there's nothing wrong with them, excessive grooming. So brushing your hair, putting on a lot of makeup. This might involve picking at your skin and seeking reassurance from others. Also doing a lot of comparing to others in comparing their bodies. So this is specifically in response to their concerns that something is wrong with them. And so this is obviously going to cause clinical distress across dimensions, not better explained by substance use or medical issues. And we have some specifiers that we can work with. So one being muscle dysmorphia, which is something we see more in men, but I think we're seeing more and more in women. So this is individuals who might work out excessively to get bigger muscles, and they constantly feel like their muscles are not big enough and they have to get them bigger. Also concern that their body is just too small in comparison to others. So again, we see this a lot in the fitness community and the weight training community. The next is hoarding disorder. So prior to the DSM-5, this was a specifier of obsessive compulsive disorder, and now we see hoarding disorder with its own diagnostic category. So hoarding disorder is persistent difficulty with parting with possessions, regardless of their value. So these are not holding on to things because they have clear value. This is holding on to everything for fear that something bad would happen if you get rid of them. So it's really this need to save items and distress in discarding them. It's less about the items, it's more about the fear and discomfort in discarding these items. And so the difficulty is really about not being able to get rid of things, and therefore the items and the possessions accumulate to the point where living areas are not able to be used as intended. And in the extreme, it's to the point where living conditions can become dangerous. So when you think about like the show Hoarders, and let me tell you, I am not a big fan of TLC. You'll see I use a lot of the clips as examples of things And doing that with the caveat of I don't love TLC because I do feel like they don't necessarily always depict mental illness accurately, and to some degree are a little bit exploitive of these individuals because they sort of make a circus of displaying their symptoms on television. However, I use them a lot for teaching purposes. So know that as you're watching this clip, it's with the caveat that I don't love TLC in general. We'll have the same rant with Dr. Phil in a later video. So in extreme forms, we're looking at living areas becoming compromised to the point of dangerous living conditions, hoarding of animals, hoarding of items, etc. And if living areas become uncluttered, it's because of third parties being involved. So family members, cleaners, authorities saying that something is no longer livable, or professionals coming in to help. Again, same things we see with other disorders, clinical distress consistently across dimensions, not better explained by things like traumatic brain injury. And we have a specifier to note those really extreme cases where it's to the point that a space is so full it is no longer livable. Finally, we're looking at trichotillomania, or trick, and this is excessive pulling out of hair to the point of excessive hair loss. Even in attempted and repeated attempts to decrease this activity, you still see that recurrent compulsion to pull out hair. And we want to make sure that this is not a symptom of body dysmorphic disorder, obsessive compulsive disorder, or any other cause. Sometimes we see hair pulling and then eating of the hair. Sometimes it's just pulling out hair. It's not always hair on your head also. Sometimes it can be pulling out hair on other parts of your body as well. And excoriation is similar to trick. It's just instead of hair pulling, it's skin picking. So this is pulling at scabs or pulling at skin to the point of creating lesions, and same types of symptoms. So repeated attempts to stop, but unsuccessful, causing significant distress.